I'm Leah Bright, and this is Sharon Board. She's the clerkship director at Hopkins, and I'm the associate program director. So I would say between the two of us, we have a lot of experience working with medical students and residents. And this was something that's actually one of our mentees, Corey Zink, near and dear to her heart, as working with resilience and looking at the changing landscape of emergency medicine and what our trainees are experiencing in the emergency department, emotionally and physically, and the lack of preparation, or is there preparation therefore? So we're going to go ahead and get started and kind of talk about what our thoughts are and what we've learned, and then go from there.
Hi everyone, good afternoon. We are very thankful for our small but excited audience. Yay! So what are we going to be covering here? So our agenda is, first we're going to think about how do we deal with death. And then we are going to talk about coping and resilience. And we'll think a little bit about what we studied. And then we'll save some time at the end for discussion and some time to talk about the data that we found. So one of the most important things whenever you're embarking on a research project is thinking about why this topic matters. And as emergency medicine physicians, or potentially people who are interested in going into the fields of emergency medicine, we experience death pretty regularly. It becomes a relatively regular part of your job. And 66% of emergency medicine physicians experience patient death at least monthly. Oftentimes the death that we experience in the ED is sudden and potentially following trauma, which makes it different than some of the other services, such as internal medicine, critical care, when that patient has been kind of going through that process for a longer period of time. Now, most emergency physicians, and this could probably be generalizable to not just physicians, but also to the rest of our ancillary staff that work in the ED, experience physical or emotional responses to death. I think many of us, I know that I definitely can reflect on a time that a patient passed away in the emergency department, and that I definitely had some physical symptoms associated with that and an emotional response. And I always tell my learners that when you stop feeling that is, potentially something that is, people sometimes feel guilty that they feel those things, but I think it's really important that we do kind of feel things. Oftentimes, though, people have negative reactions to death in the emergency department. They feel guilty about it. They feel like they failed the patient. They feel inadequate. We are also more likely to develop PTSD, moral injury, and burnout, and I think that COVID has kind of highlighted that more than ever. As we go on in our careers, we kind of adapt to some of these emotional experiences, but we know that the risk of feeling these negative emotions are highest in our learners and in our junior residents. So what are our big questions? I don't think these are our most up-to-date slides, are they? Well, we'll deal with it. It's weird, it looks different than what we submitted, but that's okay. We are rolling with the punches here. So what are our big questions here? So what coping skills are emergency medicine residents using to deal with death? And what kinds of symptoms are they experiencing? What education do our emergency medicine residents get on dealing with death in the emergency department? And how does education on this topic impact resilience? And are those two things related? So are coping skills and resilience related in any way? So what is currently happening? So by show of hands, for those of you who are educators or learners, how many of you have had experience formally learning about end-of-life care, death and dying in the ED, or teach it? So some people are maybe on the fence, they're not totally sure, right? And sometimes we don't explicitly say, like, now we are going to teach you about end-of-life care, right? So that may be why you're on the fence and you're not sure if you ever really had a formal education on this. And the education is really so all over the place. So at our institution, I also run the capstone course for the School of Medicine, and we're very lucky that we have something formalized in place where students actually get time to experience this and disclose a death to a family member for a patient and have end-of-life care discussions. But that definitely is not the norm, and it definitely does vary across the board. And most end-of-life education for our students and our residents falls under kind of more general palliative care topics. There's also very little formal education in dealing with an unexpected death and on adaptive coping skills or consequences of frequent exposure to this. Thinking about coping skills for physicians and emergency medicine physicians specifically, after a patient dies, what are things that we do to cope? And many of these probably look pretty familiar to you. And some of them are good, right? So we take time to talk to our friends, our family, our residency family, our colleagues. And I think that is some of the most important time and something that I've really grown to appreciate and love about my job, being on both sides of those conversations, right? So being the listener and the person who is taking the time to kind of get it all out. We exercise. I always kind of laugh about this a little bit. I happen to be an exercise for stress relief person. I know not everyone is. I love Dr. Flecken. I always say that name wrong, who is the Twitter person who has a stereotype for every specialty that are a little bit glib and kind of funny. And in the emergency medicine one, we're always riding a bike. So it's kind of funny. If you don't know what I'm talking about, come up to me after. We'll Google some videos. And then something that is both good and potentially bad is going right to the next patient. And that's probably something that we all have experienced or will experience, where you leave this very traumatic situation and you realize there's 4 patients waiting to be seen, or 2 residents and a student who are waiting to present to you, and you sort of just have to put on your game face and keep going. And some of that is good, right? Some of that is, an adaptive behavior, but potentially it can be maladaptive because you're not giving yourself that time to process that. I'm always really struck when people are surprised of those pictures of people, outside the emergency department. We see those also, right? The nurses who are like crying. And people are, I think, surprised that that is something that happens. But I think that sometimes, having those few extra minutes to process can be very important and helpful. So going right to the next patient can be both good and bad. Things that are potentially less good coping skills are substance abuse and ignoring our own personal health and not taking the time to process these things. And then last but not least, critical stress incident debriefing is something that has been looked at and studied mainly in pre-hospital situations and in disaster situations. And this is a formalized incident debriefing process where everyone on the team gets together and has these conversations. This is something that needs to be looked at more in the emergency department. For pre-hospital situations, they found actually that sometimes these critical stress incident debriefings had like no effect or potentially a negative effect on the participants. But those situations are potentially very different than what we're dealing with in the ED. So it'll be interesting moving forward to think about how critical stress incident debriefing may affect emergency medicine physicians. We'll also think about resilience. So a high level of resilience often correlates with a good use of coping skills. I have a love-hate relationship with the word resilience. Anyone else, right? You're like, just be more resilient. And you're like, but ultimately, if kind of used and thought about in the right way, resilience can be a way to mitigate burnout. And increased attention to thinking about resilience recently can sometimes be beneficial. And learners with higher resilience may have more comfort and more ability to discuss traumatic events. So I'm going to have Leah Bright take over and talk a little bit more about the study that we did.
Hi, you guys. How are you? So we did what all good academic people do, educators, because we don't do quantitative, research, we did qualitative research, and we went to our residents and we said, and not just ours, we went everywhere and said, what is happening? Like, how are you guys doing? So via the CORD and EMRA listserv, we sent out a survey. Some of you might have actually seen it. And it explored the UGME and residency end-of-life education that people are having, so both undergrad and then post-grad, experiences with death in the ED, physical symptoms after experiencing a patient death, your coping skills, and a resilience score, which I'll talk about in the next slide. And it was also got demographics, so obviously PGY year, gender, and then actually where you were located to see if there's any difference among those. So this is a brief resilience scale, and this is actually developed in the psychology world. This particular one's actually been vetted, it's been studied, and it's actually a pretty good one. So this was the one that we picked. And the highest score you can actually get is a 5. And what's important here is that it looks at all these things in the general population, so the regular American human. Now, in all fairness, this might have been pre-COVID, is 3.7. And interestingly, somebody who is actually over the age of 70, your resilience goes down to 3.55 in the general population. For emergency medicine, it was actually, when we did our survey, so all of our residents, it was 3, so this is not faculty. So it might be a little bit different than EM in general, but for residents, it was 3.77. So at this time, they're actually a little bit more resilient, despite having gone through the pandemic and everything they've experienced, than our general population. I also just probably think they're smarter than the general population, but that might not be. So kind of what we found out, we call the good, the bad, and the ugly. So 38% were PGY1s, 24% were PGY2, 53% were female, and I guess you can figure out how many were male from that. And every region was represented, and mainly like 34% was in the Mid-Atlantic. What we found very interesting was greater than 59% responded that they had experienced greater than 10 deaths in the emergency department. And I don't know by which year, but since mainly PGY 1s and 2s were answering, that was, pretty interesting. What's also interesting, and it's not on the slide, is that 84% had experienced death on a regular basis, at least monthly or weekly. So, how often do you experience physical symptoms of death and like actual physical representation after you've been around a death? And I don't know, it definitely would say, what is that? What is a physical, and is it that you think about it later, that you're not sleeping, that you cry immediately, or all of a sudden you wake up in the middle of the night and you start thinking about it? Like, what is a physical symptom? So it's mental, insomnia, anxiety, 2, nausea and vomiting, or, dizziness or having a headache. It was interesting here is more than 68% said that they were experiencing physical or mental signs of stress after experiencing death. So it wasn't a small number, it was a pretty phenomenal number. It's also interesting, though, that we did make a correlation that when a resident identified they had a higher BRS score, so they identified as having higher resilience, they also identified as having less symptoms, which I guess would make sense. We would expect that, but that correlation was supported. And then we also said, have you experienced any of the following after a patient death in the ER? And as I noted, a large amount of residents said that they had experienced stuff. And we also noticed that with this correlation, it was that the lower BRS scores, the lower the BRS score, the more symptoms the resident actually experienced. And as you can see, what they identified was guilt, grief, persevering on, like they couldn't stop thinking about the actual experience, to insomnia and flashbacks and anxiety. So I'll let you guys look at that. It's an interesting slide, and I actually think it's important. Of interest, 1/3 of our respondents said they had no symptoms, they were fine, but that same 1/3 went on to answer another question where they identified that they did have some signs of detachment and sometimes nausea and sometimes insomnia. So even though they thought they didn't have any signs, they later on did identify that they had signs. And I don't know if they thought that like a detachment feeling was a normal or actually healthy. So they didn't recognize it as an unhealthy maladaptive coping skill. And that's what we're wondering is, like, oh yeah, I'm totally detached, I'm cool. Not realizing that we actually were like, that's not a positive, that's a maladaptive coping skill. So I think that's probably, we're not also teaching, as Dr. Board said, that detachment is not normal, right? It could be a red flag, a sign that you're not doing well. So then we talked about ways that people were using coping mechanisms or using things to get better. And what we did notice is that we're using a wide range of adaptive coping mechanisms. So people are using, like as we talked about, communication, they're using exercise. But the maladaptive was really a lot of avoidance, and then on the smaller scale was alcohol and drugs. Now, we thought that was interesting because emergency medicine is unfortunately known for having issues with substance abuse. And we suspect one of two things. Either they're not reporting the drug use because people are either in denial, don't want to talk about it. Even though it's an anonymous survey, they just would rather, I call it what their truth is. They do drugs once in a while, but in their mind they think it's a normal, fun thing, and they don't realize maybe it's a coping thing, right? So maybe not recognizing that some of their behaviors are coping mechanisms that are maladaptive when they are using it as like, I'm just gonna go have fun because I had a bad day. And they think it's a fun time and not realizing it's actually using a bad coping skill. And then alcohol also, and we also recognize also there may not be that recognition that the alcohol is a maladaptive coping skill. We all joke, and we'll have a bad shift. We're like, God, we could use some margaritas. And we're like, why is a bad shift automatically mean go have a margarita, right? That's not a good coping skill. It sounds a lot of fun. I'd love to go sit outside and have a margarita after a bad shift, but is it because I'm sitting down with my friends and we're talking about it and we're like working through it, or am I just drinking, right? So it's how are you using that? So how does education relate to resilience? And looking at this, we actually went by what was being taught and actually in what kind of format that it was being given in the different levels of education. So we have like the undergraduate and then we have the postgraduate. So we look at lecture, small groups, and simulation. And what was interesting, as you can see on the very last column, the only thing that we actually found a correlation with is that residents had a higher resiliency score if they had had simulation and residency that went through a trauma death or end-of-life experiences. That was only correlation that were actually, nothing else really was helpful. We also didn't identify a type of coping skill that affected resilience, but I think that would be normal, right? Everyone has different ways of coping that affects their resilience. Introverts, extroverts, we all have different ways of doing stuff. But there's no, so we don't have like a good answer, and everyone go learn yoga, it really does help, but it's not true. So interesting takeaways. We employ many adaptive coping skills to deal with death. EM residents experience many symptoms after death. And like I said earlier, lower resilience is more likely to experience anxiety and insomnia. Higher resilience, less frequent symptoms. And again, the end-of-life SIM and residency has a significantly related to higher resilience. And we were pondering this, and we don't know if maybe it was an avenue for people to work through what they had actually experienced, to talk about their experiences, or to actually, and then walk away from that and understand that what they were experiencing was normal. And we also think that probably in medical school it doesn't work because I think experiencing death is still very abstract because we teach them as they're coming into their clerkship, so they really haven't actually seen it yet. And then early end-of-life education in medical school does not impact coping skills or resilience. So this probably needs to be taught at the post-grad level and not at the UGME level. And as we say, not yoga again. So the challenges to implementing meaningful support to help our trainees, creating realistic scenarios to interact with death, and emphasis on adaptive coping skills. And being very realistic when we joke about going out and having a beer after a bad day, what that means. And I have to be honest with you, these were not the slides that we've been practicing off of. I walked over and I was like, that's not the right one. He was like, Similar information, but we just got thrown through. Fake it till you make it. Yeah, that's our team. And so believe Blue sitting right behind you, and he's actually doing some of that work on the debrief, the critical incident debrief, and seeing if it's more adaptive to emergency medicine. Our thought being that what we're experiencing is expected. We expect to experience death, whereas in the other debrief scenarios is unexpected disaster like 9/11. Like we didn't expect the Twin Towers to crash, right? But you expect. So she talked about the Red Cross. It's unexpected disaster, and it was shown not to be a very helpful debrief. But we're like, we expect to see death. We know we're going to see death. You go into emergency medicine knowing you're going to see someone die. So can we do a debrief when that happens and you begin experiencing those feelings to help medical students and our learners work through that? This is actually Blue's project. Work through it so that you have a positive experience from it and positive coping skills and not learn maladaptive coping skills. So.
We're studying psych first aid.
I'm sorry, what?
We're studying psych first aid and facilities defects.
Okay.
After, we're not calling them critical incidents
Yeah.
because, whatever.
Yeah, because it does have that, stigma from the Red Cross. Yeah. Yeah, absolutely. But who's had that code, horrible trauma, and you look across the room and that poor medical student is like a deer in the headlights, and like, what did you just do to that patient? I don't understand. And we're like, oh God. Yeah, exactly. They're like, are they cold? I'm like, I'm not breathing. It's okay. So but making sure that they understand what just happened and walking them through it, and that we do debriefs after trauma. So it's like what went well and what didn't go well, and that was not helpful. Like, yes, we found where the crack tray was. I don't want to talk about that. So, it's something that's something that's very near and dear to Dr. Manila's heart. So thank you guys. Sorry, it's freezing in here.
Thank you so much